My name is Brian Wade. I'm a urologist at Urology Centers of Alabama in Birmingham, Alabama, and today I'm going to talk about prostate cancer. Prostate cancer is a very common cancer that we see among men. It's the number one diagnosed cancer among men. About 230,000 people in the United States will be diagnosed with this, and it's the number two cause of cancer deaths, with about 30,000 men that will die from prostate cancer. So it's a very common thing. The difficult thing about prostate cancer is actually diagnosing it because there are very few symptoms. So the two most common ways we screen for patients is with a PSA, which is a blood test, and a rectal exam. We now recommend that we have a baseline PSA around age 40 and a rectal exam, particularly men with a family history of prostate cancer or African American men because of their high risk of contracting prostate cancer. Otherwise, there are very few symptoms with that, and so that's why we recommend screening. Once there has been a determination that there is a possibility of prostate cancer, we recommend a prostate biopsy. That is something that we do in our office. It sounds a lot worse than it is. It takes about 10 minutes. We look in the rectum a couple of inches with an ultrasound, and we measure the prostate. Once we have a size of the prostate, because larger glands can make more PSA, so we want to know exactly what size, we actually then numb up the prostate with a local anesthetic. Once we have the prostate numbed, we are able to take several biopsies through the ultrasound. We send all of that to the pathologist, and he or she sends us a report in a few days and lets us know what they see. If there is prostate cancer there, what we do is bring the patient back in and have a long discussion with the patient. We kind of refresh their memory on what their PSA was, what their exam showed, and kind of bring them back up to speed because they're going to be anxious about the recent finding of prostate cancer. We then go through all of the different treatment options after we have staged the patient. Not everybody's going to have the same conversation because when it comes to prostate cancer, it's a very slow process in a lot of men, and so not everybody is going to fit into the same little box as to what their treatment option is going to be. So we factor in the patient's age, the patient's overall health, what their PSA was, and what their Gleason score from the biopsy showed. There are basically 5 different treatment options for prostate cancer. Some of these are with an intent to cure you of prostate cancer, and some of these are more to monitor the prostate cancer. One of them is called active surveillance, and that's where the patient has either a very low-risk cancer or has a lot of other medical issues or is older, and their chances of having a complication from prostate cancer are low. In that scenario, we'll check PSAs on every 3 to 6 month basis, sometimes re-biopsy the prostate to make sure there's not any progression. At any point, if there is a change for the worse, we then can offer a treatment option. Another option that we use, not with an intent to cure, but in very specific scenarios, is called hormone therapy, where we actually can manipulate the hormone testosterone, which is a hormone that's always been in your body, but it also can kind of tell the prostate what to do and kind of feed the prostate as well as the prostate cancer cells. So if we manipulate that hormone with a shot and sometimes a pill, we can actually bring the PSA down. The problem with that as a primary treatment is that eventually the prostate cancer can figure out a way to get around that treatment. So we don't use it typically as a primary treatment in a lot of men. We use it kind of in addition to other treatments. The 3 main ways that we treat prostate cancer are with cryosurgery, which is freezing the prostate, radiation therapies, and surgical removal. Cryosurgery is where you actually freeze the prostate cells. It's an outpatient procedure, and between cycles of freezing and thawing, we're able to kill the prostate cells. We use that mainly in low-risk prostate cancer patients that have a good long-term outcome. The majority of ways we treat patients are 2 main therapies: radiation therapy and surgical removal. With the radiation therapy, there are 2 types. There are what's called external radiation, which is what most people think of, where you are laying on a table and you get radiation from the outside in. The other type of radiation is it's called brachytherapy, and that is a seed implant radiation. That's an outpatient procedure, and you get actually radiation from the inside out. Both are very good treatments. We mainly use the seed implant with low-risk patients. At Urology Centers of Alabama, we have a radiation therapy in our office, and we get very good outcomes with what's called IMRT or IGRT radiation therapy. The surgical removal of prostate is another option for patients that have prostate cancer. And the majority of the way we do that now is it's called Robotic-Assisted Laparoscopic Prostatectomy. The problem with the prostate is kind of where it lives. It's way down in the pelvis, and it's hard to see with an open incision. So with laparoscopy, we were able to get right real close to the prostate, and we have a very precise view of what we're doing. So we're able to remove the prostate, connect the bladder and the channel or the urethra back together in a very precise way, and that gives us good postoperative outcomes from a cancer control standpoint, as well as from some of the potential side effects, which are incontinence or loss of urine and erectile dysfunction. After any treatment for prostate cancer, there are some potential side effects, mainly incontinence and erectile dysfunction, and you will most likely need supportive services with a continence clinic and possibly an erectile dysfunction clinic, and those are some of the services that we offer here. The most important thing with prostate cancer is being screened and finding an early diagnosis. That gives you the best chance of being cured from this. So I definitely recommend having yearly exams, yearly PSAs with a baseline around age 40. I thank you for your time today. I hope you found this information informative. I'm Brian Way with Urology Centers of Alabama and Birmingham. And again, I want to stress that the most important thing from today is prostate cancer is a very common type of cancer, and we definitely recommend you be screened yearly starting at the age of 40.